I don't think that all doctors who are doing this are doing it because of explicit weight stigma. I think there's a lot of implicit bias that happens. I think their training misleads them about what the research says. And I think the research misleads them because often it's constructed by people with financial entanglements with the weight loss industry.
Hi, everyone, and welcome to the Hi-Fi Health News Podcast. I'm Erica Grotto. If you're on a GLP-1 or considering taking one, I have some important information for you. These drugs are in high demand, with an estimated 1 in 8 Americans taking one for diabetes or for weight loss, but they come with a high price tag and some serious side effects. Joining me now is Ragen Chastain, a researcher and activist focused on the intersection of weight and healthcare. Welcome, Ragen.
Thank you so much for having me, Erica. It's good to see you.
So before we get into the discussion of GLP-1s and weight in general, can you tell me a little bit about your background?
Sure. So my background is educationally in research methods and statistics. And a little over 20 years ago, I actually was looking for myself for the best weight loss method. And I decided to try to find that by doing a literature review of the weight loss research. And at the time, I was not in school. I didn't publish. I had a corporate job. This is just kind of the mega nerd that I am in my life, that this is how I try to solve my problems. And so I did that literature review. And what I found was so surprising that I did the whole review a second time. And what I found was that there wasn't a single weight loss intervention where more than a tiny fraction of people actually succeeded at anything approaching significant long-term weight loss. And so that sort of got me down a rabbit hole that has become now my career of speaking, writing, and researching on the intersections of weight science and weight stigma in healthcare. And so that's kind of how I got here.
So what's your current focus then?
I started out looking for the best weight loss method, and what I ended up researching was options for what's often known as a weight neutral or weight inclusive health, where the focus is on supporting health directly rather than trying to manipulate body size as a path to health. And so a lot of my work is in researching and writing about weight neutral or weight inclusive health. And then the other side of it is analyzing the research around weight science and weight loss.
And there are some negative consequences, aren't there, to having these discussions with your doctor if you are a larger person trying to lose weight over and over again? There are some health consequences there too, aren't there?
Yeah, so weight cycling or yo-yo dieting is the outcome of the vast majority of intentional weight loss attempts. And the research for that goes back to the 1950s. And in fact, a study called Stunkert et al. That looked at 100 people in a New York hospital weight loss program and found about a 95% failure rate, but also analyzed the previous 30 years of research and found the same thing. So we've got now about a century of research that shows that the vast majority of people will lose weight and then gain it back. And the problem with that is that process, which is known as weight cycling, or we call it colloquially yo-yo dieting, is that it can have negative impacts on the body. It has been associated with increased overall inflammation and all of the health outcomes that can come from that, with increased cardiovascular disease and increased overall mortality. And so, for example, Bacon and Aframore found that the entirety of excess mortality was associated with quote unquote obesity in both Framingham and the NHANES could actually have been from the impacts of weight cycling. And one of the things we see consistently in research that tries to blame being higher weight for health issues is that they scrupulously avoid talking about, letting alone controlling for, the confounding variable of weight cycling or the confounding variable of weight stigma.
So that kind of brings us to GLP-1s and their promise of lose the weight finally forever, right? And please correct me if I'm wrong about any of this, but just for the audience's sake, these drugs were originally formulated for diabetes care, right?
Exactly right.
And there's a side effect of weight loss, and so they started being prescribed for weight loss, but to maximize the side effect of weight loss, the dosages go up, right? The problem is all of the other side effects come along for the ride. You hear about them being a pretty unpleasant drug to be on. And I read somewhere that about 65% of patients who take them for weight loss discontinue use about in less than a year. They're also incredibly expensive. They can cost up to $2,000 a month out of pocket. What is your take on GLP-1s for weight loss?
Yeah, so you're exactly right. These are medications that are solid type 2 diabetes drugs. They're not necessarily frontline drugs because they have more side effects. But for people who are contraindicated for other drugs, for people who can't achieve the glycemic management they want to on other drugs, GLP-1s can be very effective for type 2 diabetes. And so the idea was, okay, if the type 2 diabetes dosage creates a little bit of weight loss. If we gave people a lot more of the drug, would it create a lot more weight loss? And it did create more weight loss, and that's how these got approved for weight loss. So what we're finding in terms of efficacy is when you really analyze the studies, there are some big red flags. So, for example, with tirzepatide or Zepbound for weight loss, Mounjaro for type 2 diabetes is that same drug. They did a withdrawal study where they put patients on the drug for 36 weeks and then they took half of them off the drug for a year. And 10.5% of the people who were still on the drug ended up gaining back more than 20% of the weight that they had lost in the first 36 weeks in the next 52. The people who go off the drug gain their weight back really rapidly. That's been shown since the first withdrawal studies. Also, in these studies, they define maintaining weight loss as having regained less than 20% of the weight. So the 80-ish% of people who were considered having maintained their weight loss may have gained back up to 19.9% of the weight loss during that next year. So it's not clear from the research that this is something that can help people lose weight and keep it off for life.
According to the healthcare industry, obesity is a problem. More than 42% of U.S. adults over 20 meet the criteria. And that has been linked to health issues like diabetes, heart disease. So what do you think is the way forward there, if not weight loss?
So being higher weight, the health issues that are linked to being higher weight are also linked to the experiences of weight stigma and weight cycling. So when we talk about what are called like weight-related health issues or quote obesity-related health issues, what we might also be or actually be talking about are weight stigma-related health issues or weight cycling-related health issues. So we don't know what higher weight people's health outcomes and lifespans would look like if they were not constantly subjected to weight loss attempts and weight stigma. So for me, when we look at the body of research that looks at direct impacts of behaviors on health, we find that behaviors that are a better predictor of current and future health than is weight or weight loss. And so for me, it's about moving toward a weight-inclusive health model where we focus on health directly. We know that we have weight-neutral interventions for all of the health issues that higher weight people get because thinner people get those exact same health issues. And they get interventions that are not about manipulating body size as an attempted path to health.
So now I want to get to what you tell patients about this, because I know there are people watching who are saying, but I want to lose weight. My doctor says that I need to lose weight. What do those folks do when they're in that exam room and the doctor is telling them you need to lose weight? Or even if they're just thinking, okay, well, I want to be healthier and I've been told that I need to lose weight for my health. What would you like them to think about?
So I want to first point out that weight loss isn't a behavior, and that there's no research that shows any set of behaviors that leads to significant long-term weight loss. And when I'm talking about long-term, I'm only talking about 5 years, right? We don't even have research that people can sustain weight loss for 5 years, let alone for life. The vast majority of weight loss attempts are going to end in weight cycling. People are going to lose weight short-term and gain it back long-term. And that's not because people are doing it wrong. It's because the body changes physiologically in response to these weight loss attempts to really make itself into a weight regaining, weight maintaining machine. So, what I would suggest focusing on are interventions, and that can be behaviors, that can be medications that support the person's health directly. right? Even if somebody wants to lose weight, and that makes sense, right? We've been told forever that weight loss will bring increased health. Also, weight stigma is real and it impacts higher weight people in every aspect of our lives, relationships, employment, just literally our ability to fit into spaces. So it's not surprisingly that people want to change themselves to essentially appease their oppressors, right? And I don't take away anyone's option to do that. I take a really firm view of bodily autonomy. For me, the problem is it's not likely to work. And so people are going to end up, again, being higher weight. And in a lot of the research, people not only regain the weight that they lost, but they regain more weight than they lost. So people, if they believe that body size is the issue, there's a pretty high likelihood that they end up higher weight than when they started due to weight loss attempts. And so I think in in a large part, and most of my audiences are medical providers. So I'm having this conversation really often with them. And the concept of informed consent. Patients deserve to know that there's almost no chance that this is going to lead to significant long term weight loss. And patients should know that if it doesn't, that's not their fault.
Do you think that it almost works at cross purposes too? Because if you do things that you know are going to improve your health, like we know exercise is good for you, right? We know that eating fruits and vegetables is good for you. If you try to make these lifestyle changes in the name of your health, but you don't lose weight, you probably stop doing them, don't you?
Exactly. And exercise is a really good example. There's great research, Gazer and Angadi in 2021, Wheel Dryer et al. In 2024, that finds that physical movement improves health regardless of body size change. Right. In Wheel Dryer et al., they found that people who had high cardiorespiratory fitness had similar health outcomes regardless of size, but people who did not had similar health outcomes regardless of size. Right. So, but what we tell people is, oh, exercise will make you healthier because it makes you thinner. And so they embark on an exercise program. They might lose a little weight short term, then they plateau, they gain it back, and they assume that the exercise isn't working.
I want to hear about some of your tips and your tried and true advice for patients going into the doctor's office from the time they walk in to the time they have the conversation to the time they're talking about medications or any kind of interventions.
First of all, declining the weigh in. I always decline the routine weigh in. There may be times when people do need to be weighed in, but they don't need to be weighed in when they go to the dermatologist, for example. They don't need to be weighed in every time they go to the doctor's office. If they're trying to dose medication by weight, if a patient has like a heart condition where they have, fluid retention and they need to be measuring that, those are times when weight is necessary. And so I typically just they bring me, they point to the scale and I just smile and say no thank you and I kind of keep going because you're not allowed to just wander around a doctor's office, so they usually at that point just come with you. Or just saying, oh, I'm exercising my right to informed refusal of weigh-in. And I find that that's helpful because if they don't have a number to grab onto, then it avoids some level of practitioner weight distraction. In talking with providers, one thing to do is call ahead if you have options for what providers you get to see. Calling ahead and saying, I'm looking for a provider who will give me weight inclusive care, which means a provider who is not going to give me weight loss recommendations. Is there a doctor here who can do that? And in my experience for myself and advocating for other patients, that's something that they'll usually be honest about. In talking with a provider, a question that I have found that kind of can circumvent the whole discussion is to say, oh, what would you do for a thin person who has this health issue? And often that can just move the discussion along. Right. And you can add personal details. Look, I have a history of weight cycling. And, I understand that that leads to harm, or I have a history of disordered eating or eating disorders. And so weight loss isn't appropriate for me. Or going back to that sort of more intense, I'm exercising my right of informed refusal of weight loss as an intervention. What other options do you have? Our rights to informed consent and refusal are absolute. And so we're allowed to say, look, this isn't an intervention that I'm interested in. I'd like to know what the other options are. And often you can then go back to that. What would you do for a thin person who has the same health issue? When doctors are recommending or prescribing medications, you can ask them, what is the purpose of this medication? Right? Are you prescribing it for this health issue that I have, or are you hoping that it will change my body size? One thing that can happen that is sort of under the radar of patients is that providers can pick and choose from the available medications for a health issue based on whether or not they think that that might cause weight gain or they think that it might cause weight loss. And so sometimes patients who are higher weight, especially, aren't given all the options because the doctor assumes that the patient wouldn't want a medication that could cause weight gain or would want a medication that would cause weight loss. And so asking real questions about that can be helpful to get the medication that is going to be best for that patient and to have that informed consent conversation with the provider. My last tip is about shifting the burden of proof. So, my tendency, because I do this for a living all day, every day, is to come at a provider with all the information I know and all the research I know. And what I have found can be more helpful is to say, oh, my understanding is that there's not a single study where more than a tiny fraction of people actually succeed at long-term significant weight loss. So I'd love to see the research that you're using. Like, would you mind sharing that study with me? So you can shift the burden of proof. If you think this is a good idea for my care, then you should have some research that backs that up. I don't think that all doctors who are doing this are doing it because of explicit weight stigma. I think there's a lot of implicit bias that happens. I think their training misleads them about what the research says. And I think the research misleads them because often it's constructed by people with financial entanglements with the weight loss industry.
You've talked a lot about different types of research, where there is research, where there is not research. What is your dream research project into weight and health?
My dream research project is a big randomized controlled trial that looks at weight neutral interventions and their impact on health. One of the big problems in research is that most of the research around body size is earmarked for quote unquote obesity treatment and prevention. So if you just want to see if you can make higher weight people healthier, there's almost no money to do that.
All right. Well, thank you so much for sharing these thoughts. I've learned a lot. I think viewers have as well, and hopefully have learned a few things that they can take with them into their healthcare. So, Ragen Chastain, thank you so much for joining me.
Thank you so much for having me.